En un minuto, dando tiempo para que más
We will
gente se
begin
conecte.
this seminar
Good
in 1
morning
minute.
and welcome to everybody who's connected. We will start the webinar in 1 more minute, allowing time for more people to connect. Buenos días, Lorena. Muchas gracias por tus saludos en el chat. Y invito a más gente para saludarnos en el chat o poner cualquier comentario en el chat. Welcome to everyone, and I invite you to provide remarks or comments or say hello to everybody in the chat while we wait for others to connect.
Good morning, and this is Dr. Mansour from Antigua.
Oh, welcome.
Everyone.
Thank you very much, Dr. Mansour, for connecting. And we will begin the webinar shortly, and we look forward to your interventions as part of the panel.
Sure, thank you.
Thank you.
Good morning, everyone. This is Roma Bridgel Nagasa from Trinidad and Tobago. Welcome. Good morning to everyone.
Oh, good morning. Thank you, Roma, for connecting. And we also look forward to your intervention in the country panel.
Thank you.
We'll get started shortly. Okay, so I see we're 2 minutes after 10, so let's get a start. Muy bienvenidos a todos y a todas. Good morning and welcome to the PAHO webinar on documenting cases of violence against women and girls and recording the health sector response, where today we will be launching an information kit on how to strengthen health administrative data on sexual and intimate partner violence in the region of the Americas. And this webinar is being held as part of the PAHO commemoration of the 16 days of activism against gender-based violence, which provides an invaluable opportunity to help us raise awareness about the profound impact that gender-based violence has, not only on the physical and mental health of the survivors, but also at a societal level and on the development of our communities. So let us begin our webinar with opening remarks by PAHO leaders. And we will begin with remarks from our department director, Dr. Anselm Hennis, who leads the Department on Non-Communicable Diseases and Mental Health, the department in which the violence program resides. So welcome. And if we could see Dr. Hennis's remarks. Thank you. I'm sorry, I'm not hearing audio. I'm not sure if others are. The audio doesn't seem to be working. Maybe we could reload, Sharon?
Let me see.
Mientras que esperamos, solo para recordarles que
While we
tenemos
wait, simply to
interpretación
remind you that we
simultánea.
have a
Solo
simultaneous
hay que
interpretation.
aprender,
You just have
el
to
idioma en el globo.
select the language of your choice. If you go to the bottom of the screen, to the interpretation globe, and you select the language of your choice, and then you have access to simultaneous interpretation because the session will be held both in English and in Spanish.
And we're going to try one more time to see if we can get the video message from Dr. Anselm Hennis, Director of the Department of Non-Communicable Diseases and Mental Health.
Representatives from PAHO member states, experts and colleagues, ladies and gentlemen. It is indeed an honor to welcome you to the virtual launch of the information kit on documenting cases of violence against women and girls and recording the health sector response, how to strengthen health administrative data on intimate partner violence and sexual violence in the region of the Americas. Violence against women and girls remains a major public health challenge in the region of the Americas, affecting an estimated 1 in 3 women aged 15 years and above. The health system has a critical role to play in the prevention and response to violence, as outlined by the PAHO strategy and plan of action on strengthening the health system to address violence against women. One of the strengths of the health system is its access to valuable data to monitor the response to violence, to sensitize others, and to advocate for change. Accurate, comprehensive, and timely health administrative data are indispensable for designing evidence-based policies, strengthening health systems, and ultimately improving the care provided to survivors of violence. By generating comparable statistics on incidents of violence, survivor characteristics, the services offered, and long-term outcomes, health systems can effectively monitor key indicators and make informed, evidence-based decisions about how to improve quality of care and enhance survivors' access to support and justice. The importance of solid health administrative data and violence was most recently highlighted by the COVID-19 pandemic. This event marks a significant milestone in our collective efforts to strengthen the health system's response to violence in the Americas. Today's event launches the first of our information kit on how to strengthen health administrative data on intimate partner violence and sexual violence in the region of the Americas, including its regional form for documenting such cases. This kit is designed to standardize data collection, align with key regional health indicators, and be adapted for both electronic and paper use. It represents a practical, scalable solution to enhance the availability of actionable data, empowering clinicians, policymakers, and advocates alike. The kit was made possible thanks to the support from the Spanish Agency for International Development Cooperation and benefited from the collaboration of multiple Ministry of Health representatives, different teams at PAHO, as well as experts and practitioners from across the region. This is not a new topic for the Americans, and there are many experiences that we have been able to draw on to learn from. Today's launch is more than a launch of a tool. It is a call to action. By strengthening the foundation of health administrative data, we can strengthen the capacity of our health systems to advance responses to violence that is survivor-centered, culturally sensitive, and rooted in ethics. I encourage you to actively engage in the discussions, share your experiences, and explore the applications of this tool in your context. PAHO stands ready to work with all of you to take this important agenda forward. Together, we can turn data into action, action to lasting impact. Thank you for your commitment and participation. Welcome.
Thank you. Those were welcome remarks from Dr. Anselm Hennis, the Department Director of Non-Communicable Diseases and Mental Health, in which the Violence Program resides. And I realize I forgot to introduce myself. I'm Silvana Luciani, the Unit Chief for Non-Communicable Diseases, Violence, and Injury Prevention. And I'm pleased to be moderating this very exciting webinar in which we'll be launching this information toolkit. And as you heard from Dr. Hennis's opening remarks, it's really a call to action where we need all of you and your support to help strengthen the data and the health system response to violence. And this toolkit wouldn't be possible without the very strong collaboration that we have with our program on perinatology and the Latin American Center for Perinatology and Women and Reproductive Health. And so I'm pleased to introduce the director of the Latin American Center for Perinatology, Women and Reproductive Health, Dr. Susana Sarruya, who will also deliver some opening remarks for this webinar. Susana, over to you.
Muchas gracias, Silvana, y buenos
Thank
días
you
a
very much,
todas.
Silvana. Good morning, everyone.
Hoy es un día muy importante
Today
para
is a
todas
very
nosotras,
important
¿no?
day
Nosotras
for all of
mujeres
us, for
nos
us
conocimos en
women.
91 en una reunión muy
We
importante.
met in
Se
91 in a
decidió
very
a
important
Chile ese
meeting where
año,
it
en
was decided
91,
that as of
era una reunión
that
de
year,
women's leaders.
and that was a
Nosotros
meeting of women's
elegíamos a
leaders in New
cada
York,
mes del
we decided that we would go from 25 November to December 10, launching a campaign in order to make visible this issue of violence. And violence against women is a structural issue in our societies. We live in a society that is a machista. It's a very simple world that defines the gender inequality that we have between those of us who are women in different forms. There are different ways of being women and the difference with the men. And sometimes between women themselves, but violence is something that is structural in society. And it takes place because of an inequality that changes in all countries. This year, in particular, this campaign is dedicated to commemorate, to celebrate the Beijing platform that took place 30 years ago in 91. And the launch itself, this virtual launch of militant activities where we dedicate these days to holding events. And luckily and fortunately, our institutions and their leaders, as Dr. Hannes, as Silvana, and there's a video by our director on the web, they dedicate this to make it visible, to work on this issue and to convene people. And we have 130 people participating here that are devoted to this. Why is this important? Why do we have to continue working on this? Because today, when we know more about the problem, we know that 1 out of every 3 women have suffered from violence in their life. We know that when we speak of women, there's no unique, one single package. Not all women are the same. On the contrary, women are different. And here I'd like to draw the attention to the most vulnerable women, those who are on the extremes of the age groups, young people that sometimes are involved in violent relations, and the older people, violence against older women, and not even talking about women with disabilities or women that are in places that have less access to information or who belong to cultures that where, for example, this right is taken away from them. Unfortunately, we also lived after the pandemic and during the pandemic a growth in the numbers of violence, and that has led to 2 numbers. We don't like talking about them, but unfortunately, have seen a rise, which are feminicides and suicides, which in a way, many a times, it is a response from that woman to that situation where they're stuck. They cannot leave out of that situation. But it is a day where we will become acquainted with something that is a very important progress. And I'd like to thank the team that is represented here by Silvana and the department and the club itself for this wonderful work that we've been doing together with the leaders of the nations, and there are many. I will not quote one in particular so as not to forget, but that brings today this toolkit, this toolbox, so that we can work on this. All of you know that health systems, the healthcare can mitigate these actions. We have an essential role to play when we train someone on any issue. We talk about contraception, prenatal visits, things that are happening with these women and to perceive many things, things that she cannot say. So I do have a message for today, and that is look at the eyes of women. Look at the eyes of the women that you recommend to be taken care of. In the trainings, we see people that come to us telling us that violence is invisible. Women are ashamed to share this. They're not allowed to do so. They're afraid. And many times they suffer a whole life without talking about their problems. We, as a health system, have the possibility of assisting these women, which is precisely what we're going to present today. As a health system, we can mitigate these conditions. And these actions, even though this is an intersectoral action with education, with the work for women, with the poverty distribution, with a whole set of policies that empower women and leave women in a better place in order to come out of these situations of violence, we have a privileged role to play in helping them when we see them in the health
Estoy
services.
segura que será un excelente
So I am sure
webinar.
that this will be an excellent
Los
webinar,
compañeros que van a
and our
presentar, los
colleagues who
invitados de
will
los
be
países,
presented,
también
the guests
agradecemos
from the different
esas
countries, and
personas
we're also
con
grateful to them,
mucho
are
compromiso con el
people that
tema
have
y estamos
a
para ver
huge
su visión
commitment
del
with
Centro
this issue, and
Latinoamericano de
we're ready and
Perinatología,
available with
Unidad de
the Latin
Estudio de
American
Mujer y
Perinatology
Reproductiva,
Center, the
para
health
siempre, no
unit
no
for
solo
women and
los
reproductive health
17 días de la
forever, not
Constitución
only during
por ese
the
ejercicio social
17
y de
days
violencia
of
contra las mujeres.
activism
Muchas
in
gracias.
fighting against
Muchas
this
gracias a
violence
ti,
against
Susana,
women.
y
Thank
mil
you. Thank you
gracias
very
por
much,
todo el
Susana.
apoyo
And thank you so
de
much
ti
for
como
all the
directora
support
del
that you
Centro
have
de
provided as
Perinatología
director
y la
of the
Unidad de
Perinatology
Salud
Center
de la Mujer y
and the Women's
Reproductiva y todo el
Health
equipo
Unit and Reproductive Health
por la
and the whole
colaboración
team
en violencia
for the
contra la mujer
cooperation
y
offered in
por
violence
llamar la
against women
atención y
and for
enfatizar
drawing our
que es
attention
a
and
través del curso de
emphasizing the
vida que
fact that it is
necesitamos
through our life course
estar atento
that
y
we
servir
need
las necesidades
to
de las
follow this
mujeres y tomar
closely
todas
and
las
to serve the needs of
oportunidades que
women
llegan a una
and
mujer en los
take
centros
advantage of all
sociosanitarios.
opportunities that we have when
Mil
women
gracias,
arrive at
Susana.
these health
Y
centers. So
ahora
thank you very much,
pasamos
Susanna.
al
And
lanzamiento
now we go to the launch
del
itself.
kit,
We move to
del
the launch
information
of this
kit. And
toolkit,
today's
the
event
information
is
kit.
really our official launch of this information kit that has been developed by the support of the Spanish Agency for International Development Cooperation, or IECID. And we're really pleased to have developed this toolkit with the input of many of you, our experts and our collaborators, and through the network in Latin America and the Caribbean of experts working in violence against women. And this is really a toolkit that's designed for clinicians to use in both electronic and paper format. And we'll hear today in the webinar a little bit more about the toolkit, how it was developed, and how we're hoping it will be used and rolled out in the region. And then we will also have a little bit of a discussion with our panelists from different countries around the region to highlight the importance of regional collaboration and how this toolkit can improve the administrative data for violence against women. So let's get started. And I would like to invite our regional advisor, PAHO advisor on violence prevention, Britta Baer, to present the information toolkit, which is our first ever regional template for documenting cases of intimate partner and sexual violence. Over to you, Britta.
Great, thank you so much. And I'm going to share my screen to give you a little bit of a highlight of the toolkit, which is available on our website. Okay. I don't think I need to talk about the importance of the issue. You've already heard this from the opening speakers. 1 in 3 women approximately are estimated to have experienced violence, and this is the tip of the iceberg. These are the cases we know of, and probably there's a lot of like hidden numbers that we do not know of. The impact of violence in health, in well-being, in social and economic life, or in communities themselves is enormous. And the health system can make the big difference. The health system has the capacity to identify groups at risk, to provide care and support, to refer to other essential services, to facilitate access to justice. But that means the health system needs to have the capacity, the training, the support, and the tools that it needs to play this very important role. And that is really something that has been a strong theme in the region of the Americas for decades. And this is not a new topic, as you heard Dr. Hanna say. Member states of the Pan American Health Organization across the region have been working in this area. In 2015, this is the very first region that came together where ministers of health decided that we need a regional strategy and plan of action that specifically focuses on the health system response to violence against women. That was adopted and that outlines some clear criteria of what a health system's response should look like. It outlines areas for collaboration, and it actually underlines the importance of data. Health systems have access to a whole range of different types of data that can be extremely useful in both the response to violence, in strengthening quality of care, and ensuring that any intervention is really data-driven and evidence-based. So in really response to this agenda that member states themselves have set for PAHO, we have been collaborating with many of you, with many experts and governments across the region, and with the Spanish Agency for International Development Corporation in the development of this kit of information, basing it very much on experiences that already exist, recognizing that this is not a new topic, but really coming together and realizing that, especially after the pandemic, one lesson learned has been that health administrative data, especially on the topic of violence, needs to be strengthened. We need common guidelines or common standards that we can all agree on, and that this is an issue of interest across countries in the region. So we developed this kit to, on the one hand, support health workers, health managers, health policymakers in the collection and use of administrative data on specifically sexual violence and partner violence, which are the two types of violence against women that are particularly common, to come up with a sort of regional vision and toolkit and set of resources range of like messages and instructions and experiences that can be useful to countries across the region, and thereby help to build the capacity in this very important topic. The result of this very collaborative effort is the information kit, which you see on the slide and which is available in English and Spanish on the PAHO website. And why is this really important? It is important because we know that health administrative data on violence can make a huge difference. That this can make a difference to improve what we know about use of services, access to services. It can help us monitor and improve the quality of care. It can help us ensure or facilitate continuity of work if we have good documentation in the health system. It can facilitate access to other medical legal types of services, including access to justice if the survivor wishes to do so. It can improve documentation of cases, which is providing critical data to not only inform the health system, but also to advocate for change more broadly on this important topic. This data is also critical for policy making. We want policy in the health system and beyond to be guided by data, to be based on evidence. And for that, the health system data, the health administrative data plays a critical part. And it allows us to provide long-term, short-term, medium-term, and long-term support, including following the cases of survivors and the care they receive and the consequence of violence that we can see. So for all of these reasons, and I could go on, it is a critical piece of the puzzle of a strong health system response to have health administrative data on violence. So what kind of types of data are we talking about? We're talking about characteristics of survivors, such as age or sex or where they may be based. We're talking about different types of violence that can be documented through strong health administrative data. Data about the perpetrator that is providing critical information for prevention. Data about the health consequences. If we don't have data that make it visible what the impact of violence is, it is very hard to advocate for change. It is critical to document the care provided because this is such an important tool for health ministries to document whether their protocols and policies have in fact been implemented in practice, and it allows us to strengthen referral to other essential services, including within the health system, but also outside the system, if consent has been obtained. So this is really what you see in the toolkit or in the information kit. You have a short summary targeted at health policymakers about the importance of this issue and why it's important to advocate for it. You have information for health managers around key principles to consider, including the issue of privacy and confidentiality. You have the form for healthcare, for documenting healthcare for survivors of violence, which I will show you shortly. You have a toolkit for health workers on how to use this form, and you have guidance on how to adapt the form to different contexts. Of course, this is a regional template, and we all want to encourage you in your context, in your institutions, in your countries, to adapt it, to look at it, and make it useful in your contexts. This is the form that you will find. I know this is hard to see, but the details are in the guide itself. It is the very first time that PAHO is issuing a regional template, a regional example of what can be included in a clinical history, in a form, in a register for care for violence from the perspective of the health system. It includes all of the indicators I mentioned. It has been aligned with the evidence base. It has been aligned with the regional indicators included in the plan of PAHO member states that I mentioned. And it really benefited from both experience of countries that we will shortly hear from others that have already engaged with this process, as well as multiple experts from ministries of health across Latin America, and the rest of the region to really help us fine-tune every single letter that you can see in here. So I hope, of course, this is a regional template. It requires further adaptation to your context, but I think it's a huge achievement of everybody to get to this point. I'm going to hand over to my colleague Erin, who played a considerable part in this project, in the development of the form and the toolkit, who is the consultant with PAHO in my team, who will briefly introduce what has been included. Erin, you have the floor.
Great, thanks, Britta. So I'm just going to speak a bit about the form that you will find as a part of this big toolkit that's now launched online. So as Britta said, we created this form to document the relevant clinical history and care given to survivors of intimate partner violence and sexual violence. So once they come to the hospital. So who should use this form? It's a form that we created for healthcare workers. So that can be doctors, nurses, psychologists, social workers, really all healthcare workers who care for survivors of violence in any healthcare setting. So this can be from emergency care to outpatient services and across any and all disciplines. And so this form should be triggered and should be used once any case of violence has already been identified. And we would really like to stress here that this should only be used in a private and confidential, in a safe space where the survivor feels comfortable. So this could be during initial care or even during follow-up. And in terms of populations to use it with, we created it specifically with female adult survivors of violence in mind, but we also designed it so that it could be adapted for male survivors. It could be adapted to be used with children who are survivors or with any other population in any context. And so how to adapt this, right? The form should be really used in line with any national health system protocols or health system principles that you have, such as privacy and confidentiality, and it should be in accordance with any local laws. So it should really be embedded into all of these good practices that the health system is already following. And it should always be adapted to the local context and also to the local culture. So this means considering local population needs and then also local capacities. And lastly, implementing this form really cannot stand on its own. So this is a part of broader health system efforts and strengthening approaches, which should include capacity building, such as provider training, and creating survivor-centered policy environments, and obviously striving for continuous monitoring and evaluation of care so we can estimate and study how we're doing in responding to violence. Back over to you, Britta.
Excellent. Thanks so much, Erin. This is my last slide. I just want to give you one example of why I'm so excited about this piece of work. I've already given you a long list of why health administrative data on violence is so important. One of the examples is that it allows us a whole new level of being able to monitor quality of care. Of course, survivors need to be provided with good quality care. We know that that is an opportunity not only to respond to their specific needs in the moment, it also allows us to avoid re-victimization. And lastly, it has an impact on the trust and the access to services in their community, because a given survivor might share their experience with their communities, which then will then influence how maybe their daughter or their friend accesses services. So quality of care is essential for survivors of violence. And the nice thing about having this type of data is, and it's been built into the form, is that we can now, or the system is able to monitor specific indicators of quality. I'm using here one on the slide that is an indicator that member states have set in the regional plan, but it could potentially be used in or built into any kind of quality indicator that you have in your protocol. And the form is allowing us to document cases of violence, and by extension, the system is able to allow us to assess the number of patients that, for example, have come to youth services where violence has been identified versus the number of patients that have received emergency contraceptives within 5 days. This is a critical piece of information because this is an indicator that we have, in fact, in the regional plan. And this data will allow us how well we are doing in implementing the plan in practice in the health service that we have. So I'm super excited with this type of data because it will open up a whole new level of being able to both assess quality, but also then guide our action, guide our response to this. I'm going to end it here and hand over to Savannah, but all of the materials are available on the website, and I strongly encourage you to use the chat to share your experiences, your comments, your questions, and any other comment you might wish to make. Thanks so much.
Thank you very much, Britta and Aaron from the PAHO Violence Program for showing us the toolkit and also emphasizing the benefits of collecting better data to improve the health system response for survivors of violence. And of course, we're really excited from PAHO to be able to offer this very standardized, evidence-based tool, recognizing that there may be some need for adaptation. And I thank everybody who's put some comments already in the chat. I just want to highlight one from Kelly Sopla in Peru, noting that while this is targeted to clinicians, please don't forget the midwives, o como en Perú se llaman obstetras, que son la mayoría de las personas que entrega esas herramientas y da apoyo a personas
midwives called
violencia.
obstetras in Peru
And then I
who
also
respond
want to
to
highlight
acts
also
of
the
violence in
question. I think
Peru.
that Natalie Gomez has asked, where's the link to be able to download this and what languages are available in? I think there's a lot of excitement to start using and looking at the information kit. So if we can possibly add the link, that would be helpful for everybody. And thanks to everybody who's connected. So just continuing along the presentation of this very exciting new toolkit, we have collaborated with the Latin American Center for Perinatology, Women and Reproductive Health to help digitalize the form and incorporate it as part of the SIP, which is the Perinatal Information System, which is used in more than 20 countries in the region already. So this is a great opportunity for the kit to be integrated seamlessly into health administrative data anyways. And I'd like to invite Dr. Rodolfo Gomez, who's the advisor on sexual and reproductive health at PAHO, together with Mariana Gonzalez, to talk a little bit about the SIP and how this violence information toolkit is incorporated in SIP. Over to you, Rodolfo.
Muchísimas gracias, Silvana y Brita, por la presentación que nos antecedió. Muy
Thank you,
brevemente,
Silvana and Brita, for the presentation. I want to indicate why to use the SIP. This is an old system, more than 40 years old in the region, originally developed for the baby deliveries and pregnancy control. And now this system has grown robustly, favoring care, mainly of mothers and newborns. This is a toolkit encompassing a series of tools that have improved the response of healthcare using different medical histories and the registration of individual medical history that makes it possible to warehouse, save, and analyze data. We have a roadmap allowing us to give a great evidence-based care, and it's also an effective tool for surveillance and care at an individual level and at the population level. How many countries use this SIP system? More than 25 countries. And how many health indicators. Does the system have more than 3,200 variable indicators and more than 2,500 health indicators? This is the robustness of the system. More than 30 medical history models and more than 30 automatic information tools. It's in several languages: English, Spanish, Portuguese, Dutch, and other languages. These are the countries that are currently using the system. Those on green are using the system in a control platform managed by the health ministry. Those that are in lighter green use the form in the SIP in a paper form, and those in yellow have not implemented it yet. The flags to the right represent the countries that, in addition to this, have adapted some medical histories to their legal programmatic realities and also managerial realities. Perinatal clinical or medical history is the one that was used in its origin at the SIP. We have more than 30 medical history forms: abortion, neonatal health, contraception module, identification of maternal death, COVID vaccines, neonatal COVID, and here we include the new regional form for violence against women and gender-based violence. In addition to these specific medical histories, we also have indicator reports with a single click, and there we get the description of automatic indicators agreed on a regional basis, which will make it possible to monitor the quality of individual presentation, but also to monitor the implementation of quality care in the framework of a national program. Now I stop sharing and I give the floor to my colleague Mariana Gonzalez to make a live presentation from the SIP platform. She'll show how to look and activate medical histories without going into specific details. Mariana, the floor is yours. Thank you very much, Rodolfo. This is the SIP platform. I would like to clarify that this is a test, a pilot platform, so data are not actual data. In this case, we will select the language Spanish depending on the privileges of the user that connects to the platform. Depending on its permits, the user will have different sub-platforms. This is very important for confidentiality. For example, regional form about intimate partner violence, and this record is a bit better, more user-friendly. This is a pilot record. We start with the care recording, preliminary data to ensure responsible care of these cases. For example, that survivors are in a stable situation or that they have given informed consent. Then we gather patronymical data in the identification of the survivor. It's important to record the person that comes together with the patient. Then we move to the medical and family and personal data record. Data collection is always guided by clinical requests and elements, and this is maybe the most sensitive session of this medical record is the collection of data provided by the survivor about the current violence incident. And continuing, if this applies, there are some sections of this medical history form that only applies to sexual violence or physical violence. That is the case of the record of variables related to physical and sexual aggression, and also whether the survivor shares information about prior incidents. This allows us to record this and the survivor's emotional state when coming to care. The physical exam, again, if this applies, and in all sections, there is a variable that makes it possible to indicate whether there was informed consent. All this is guided by survivor-centered care recommendations, also gynecological, genital, and sexual background. There are pictograms to make this more visual and simpler to record medical care. And finally, as Dr. Bert said, it's important to define the care provided, to record them. There can be minor, mandatory or not mandatory reporting of the case depending on the type of case. It's important to have a record of whether there was a safety assessment conducted, and then also referrals. Also, we need to indicate whether there was any legal evidence captured, but that is not a specific requirement. It's important to indicate whether care was provided based on ALMA's recommendations and all these variables. All the content of the SIP form is completed with on a prospective basis, so not a single care. There can be as many violence incidents recorded for a patient as necessary. And depending on these variables, we can analyze data or obtain a report with these indicators of violence that I already mentioned, centered on the first line of support, for example, the provision of contraceptives based on the adequate period, and also prophylaxis against sexually transmitted infections, etc. I conclude my very brief presentation here about how we have incorporated this medical history in the SIP. Thank you very much. Thank you very much, Rodolfo, Mariana, for the Perinatology Center and Reproductive SIP. This is very important, the SIP and the violence module, which is an excellent tool to capture the necessary data to strengthen the health services response to violence against women acts. And I'm happy to see that 25 plus countries that have already the SIP use this violence-related form. In the chat, I have indicated the link where you can download the kit, the tool. It's a document that you can review and look at the forms. It's in English and Spanish, and the links are in the chat.
Version of the toolkit, and the links are in the chat if you want to download and have a look at it. So thank you again to all the presenters on the kit. And now we're going to move to this session where we're going to hear from country experiences on improving data for violence against women. And we're really excited because we had a lot of input from our country collaborators in developing the toolkit. And so the aim of this panel is to give a little bit of visibility of the existing work that is happening in these countries to strengthen health administrative data and their contributions to this regional toolkit on violence, and to highlight future opportunities for collaboration. So I'm really pleased to have and welcome with us, and I invite you to turn on your camera, representatives from 4 member states. So we have from Antigua and Barbuda, Dr. Raymond Mansour, who is the consultant in the Department of Obstetrics and Gynecology at Sir Lester Bird Medical Center in Antigua. Welcome. We have next from Trinidad and Tobago, Dr. Roma Brijalal Nagasar, who's the manager of the medical research and audit at the Directorate of Women's Health in the Ministry of Health in Trinidad and Tobago. Y también con nosotros tenemos de Honduras, Tracy Lemu,
So
quien es la
from
coordinadora
Honduras,
de la
Tracy
unidad de
Lenu,
género
coordinator
del
of the
Ministerio de Salud de
gender
Honduras.
unit in the
Tracy.
Honduras Health
Además,
Ministry.
tenemos
Welcome,
de Perú
Christy.
a la
And
doctora
from
Lisa
Peru, we
Clara
have Dr.
Hernández Torres,
Lisa Clara Hernandez
supervisa en
Torres,
el Sistema de Información de Salud
leader
del
in the
Departamento
health
de
information
Salud Sexual
system
y
in
Reproductiva
the
del Ministerio de Salud del
Sexual
Perú.
and Reproductive
Bienvenidos todos
Health Department of
panelistas,
the
Raymond,
Peruvian
Tracy,
Health
Lisa,
Ministry.
and Roma. Thank
Welcome,
you very much
panelists,
for joining
Lisa,
us today and sharing
Roma, and all
experiences from
others.
your respective countries on improving health administrative data for violence against women. So the way that we're going to run this sort of panel presentation, and if we were together in a room, I would have it a little bit more dynamic, but because we're on a very flat 2-dimensional screen, I think what we'll do is just hear from individual country representatives, and we'll go in order of the countries. So of course we get to start with Antigua and Barbuda and Raymond Mansour. We would like to hear from you about what do you see as the importance of collecting health administrative data on intimate partner violence and sexual violence in your country. Over to you, Raymond.
Thank you. And thank you for inviting me to be on this panel. It's really an honor for me to be here. This is a very vital and important topic for any society. And I think that showing 176 participants on this webinar is really impressive to know that there's a lot of people who are on our team to make sure that this gender-based intimate and sexual violence against women is reduced to bare none. For us, we, of course, you're launching the toolkit today. We have seen it before, but we have not incorporated it yet into our SIP data collection. We have transitioned this year with the help of the Center for Latin America from a paper-based to a electronic-based SIP data collection now. We have been using this program since the 2017, January 2017, and currently have about 7,000 pregnant patient data that we are able to process. So this tool, this perinatal information system, is a very versatile program. Rodolfo had said that there are over 3,000 data points that you could use and process at the click of a button. And so for us to institute the data collection for our pregnant patients on our ward would be easy to assimilate this data form into our collection data. For us, we have the gender-based directorate who handles most gender-based violence on the island. And there's a special victims unit in the police force, as well as a group called Women Against Rape, who are all very active in collecting data and assisting the survivors of these violent attacks. So definitely Antigua will be on board in implementing this, just that we would now have to allow for the other parties who have been collecting this data from before, probably paper-based, but I understand that they may have a recent database from someone else that we would have to see what they're using now and see if we can assimilate what they have in the use of this program, in this kit. Thank you.
Thank you. Thank you, Raymond. And can you comment a little bit on what data do you think is most useful in the context of Antigua and Barbuda?
as it relates to gender-based intimate violence.
Yeah.
I mean, I've read through your toolkit and your data entry points from your SIP program, and I see that all of it is relevant. You go from personal history to a history of the attack, to a history of who was the attacker, to a physical exam, to then who do you refer her to? Did you refer her to social services? Does she need a place to stay? Should we find the perpetrator and put them in jail? So did we refer them to the police department? So I think all of these data points are valid for any event as it approaches the healthcare system. I would think that I wouldn't take anything out.
Okay, excellent. And then just last question, how do you think this kit will really help improve Antigua and Barbuda's response to women who have suffered violence?
I think that we can all work together to try and make this a seamless process for the survivor. I think having been through what she's been through, and then having to be berated with the amount of questions and the amount of what do you say, interrogation per se, investigation as we have to do, we would have to be trained and be a cohesive unit. So if let's say she was to approach, to say us in the ward, then how do we navigate her through all the steps that she would need to go through? And that will take, of course, a little coordination with the Directorate of Gender Affairs and, of course, the police department and, of course, the powers that be, the ministers of legal, the ministers of health, so that we can get a good working platform that Antigua can be proud of and can demonstrate to the world that it's easy to get done.
Excellent. Thank you. Thank you very much, Raymond, and to Antigua and Barbuda's commitment to use the SIP violence module to improve data collection that enables strengthening the response to women who have experienced violence. So thank you. Thank you, Raymond, for sharing that. So going in alphabetical order, we go to our next country, Honduras. Tracy Lemu, mil gracias por conectar y acompañarnos en este
Tracy,
panel.
thank you very much for connecting and sharing your experience in improvement of administrative data, sharing this with the countries here present. From the Honduras viewpoint, why do you think that it is important to collect these data and this information, and how can this help the survivors of violence? Good morning, everybody. First of all, I want to congratulate PAHO and WHO for the launch of this kit, which will be very helpful for all regional countries. And thank you very much for the invitation. And on behalf of Dr. Carla Paredes, our health ministry, greetings to all. This data, it's important to collect this data and ensure their quality to make visible the magnitude of the problem, because these administrative data make it possible to monitor the quality of care and follow up on the survivor of intimate partner violence. And also the information is useful for advocacy and to design more efficient public policies and programs in quality control. The toolkit ensures that these essential data are collected on a standardized basis, for going from survivor characteristic to the service provided based from as in response to violent acts. Thank you very much, Tracy. Can you also comment about the kit itself? How do you think that this toolkit, including the SIP module, could be used in Honduras health services? The new PAHO toolkit includes a form about SIP care, which is a valuable resource that can change the health system response. This form makes it possible to structurally document the care provided, not only with relevant data, because also in integrating this in SIP Plus, we make it possible to conduct an automated analysis of this data to improve the interagency and intersectoral coordination. And through this approach, the country can move along toward a more timely and comprehensive care centered on the survivors and the right to a violence-free life, strengthening prevention and the response to violence cases. Thank you. Thank you, Tracy. I understand that Honduras already has a protocol to address violence against women. Could you please indicate how this data that will be collected through the SIB and using the standard form could help in the implementation of the domestic protocol? Since 2022, the Health Secretariat in Honduras has been active creating and implementing this protocol of care to victims and survivors of sexual violence. Currently, we have SIP Plus in all CESALP servers so as to use the clinical file, including also a violence module adapted to the clinical history by using the protocol against sexual violence. SIP Plus is able to include electronic forms that gather real-time data aligned with the standards established within the protocol. And this will not only facilitate a standard and effective implementation, but it also makes it possible to constantly monitor and constantly improve the protocol based on these collected data. Honduras has already a successful experiences in SIP abortion, and we want to escalate the use of models and SIP Plus. This will allow us to strengthen even more the quality of care in contributing significantly to the care and welfare of sexual violence survivors. Thank you very much. Thank you, Tracy, and thanks for Honduras' commitment to use data to implement the national protocol and improve the response to gender-based violence. Eulalia Cardenas and Dr. Hernandez from Peru, please turn on your video. Thank you, Lisa and Dr. Eulalia. Thanks for connecting. Thanks for Peru's commitment to strengthen data about violence against women. I would like to start with the same question. Why is it important to collect this data about survivors of acts of violence in Peru? From your perspective, starting with Lisette, please. Good morning, everybody. Thank you very much for the invitation. This data, it's important to collect this data, this information system, because internationally these data can provide us an estimate about how many patients suffer gender-based violence. It is important to have real-time information about these numerical figures. That is why we are working in data collection, and Eulalia can also mention from the legal and regulatory area why it's also important to collect this data also. Thank you, Lisette. Eulalia.
Eulalia, estás en mute. No te escuchamos.
Eulalia, you're muted. Thank you. Good morning, everybody. For us, it's a great satisfaction to be at this meeting because we can share our work. Lisette will go in greater detail about what is the current status of the kit, because Dr. Rodolfo Gomez has been advising us for a long time. And when it comes to sexual and reproductive health in the Ministry of Health, we are responsible for detection of violence against pregnant women. We have an information system about violence, but we don't have the same information system for the delivery of the kit against sexual violence in the case of victims of sexual violence. This seems unreal, but we have been collecting this data since 2019 to make sure that the kit is used on an immediate basis, that this data can be downloaded. This has been recorded in an Excel spreadsheet. Believe it or not, this is the only way so far to collect data concerning sexual rape. Using this tool and the work experience that has been conducted, Lisette will delve into greater detail about the status of the kit. It's very important to have evidence-based data to take decisions at a regional level of authorities as to how to make interventions, what lines of interventions. In these cases, there were reported important cases, especially of sexual rape. This is very important to access to justice, especially. That is our weak link in Peru.
Thank you, and thank you very much for explaining a bit all the actions that have been taken so far. And hopefully with the SIP and with this violence module, you can expand the information and also to truly be able to collect more information about the size of the problem and to strengthen that response. So I don't know whether you can tell us a little bit about the role that you believe could be played by this toolkit, how it can be served, and how it can be used in health services in the country. We know that Peru is huge. There are many service centers, but I don't know whether you have a plan or whether you can tell us a little bit about what you're planning to do. We have 8,000 establishments with different solutions and what they offer, and the levels of centers, hospitals, clinics, institutes, and we use the Aguarret system. Dr. Rodolfo is aware of that, and we believe that therein we can use the data is very important, and we saw that in the chat. In Peru, the midwives take place and take care of the pregnant women in prenatal control. So it is important to have this kit. It would help us, as Lisette was saying, in real time to include all the data and thus to be able to analyze it on the one hand. And on the other one, in connection with the issue of the kit on sexual violation, we use a kit that has already been established on the basis of supplies, ARVs, diagnostic tests, etc. We have them in just one kit that is used in cases of emergency. So we definitely have to adapt ourselves to be able to have the information. There's no better information than the one that you do not have in the system. It is not that a Google form and based on a survey and a poll, I have clear data. We could do some sampling, but it is not official. So particularly with the kit on sexual violence and gender-based violence, we still face many problems, and we hope that this toolkit will become a reality as soon as possible in Peru, at least here, for all these issues that deal with the sexual and reproductive health. With the support of PAHO for the implementation, you can count on it for the implementation of this. Thank you very much to Peru for the commitment, and we will continue working together with Peru.
Continuing with our panelists since our last country, Trinidad and Tobago. Roma, I'd like you to perhaps comment on how in Trinidad and Tobago health administrative data on violence has been included in the development of the national policy and clinical guidelines.
Sure. Good morning to everyone, and thank you for inviting me. And congratulations to the Pan American Health Organization on the launch of the toolkit. So in Trinidad and Tobago, for our intimate partner violence and sexual violence guidelines, we thought it important to have these guidelines because violence against women is a serious public health problem in Trinidad, right? And basically, in our studies that were conducted in Trinidad and Tobago, in 2017, the National Women's Health Survey, it showed that women and girls who are survivors of intimate partner violence, they told their case mostly to a healthcare provider, right? About 13% would have informed a healthcare provider first, 5% to the police, and 4% to a religious leader. So we thought it important to include and to strengthen the capacity of our healthcare workers to manage patients who are survivors of intimate partner violence and sexual violence. And these guidelines were approved in 2022. And a part of this guidelines includes a healthcare record similar to what PAHO is launching today. And these guidelines were approved in 2022. So currently in Trinidad and Tobago, we have already rolled out this healthcare record form, which is the SIP Intimate Partner Violence, Sexual Violence module. And this was first rolled out under the Spotlight Initiative, which was from the European Union, and they funded the project, the Spotlight Initiative in Trinidad and Tobago. So how countries can roll out this intimate partner violence, sexual violence toolkit that you all have launched is similar to what we have done in Trinidad and Tobago, which started under the Spotlight Initiative. So our regional health authorities training took place on the intimate partner violence, sexual violence module, and it was on the same platform as the SIP, which was already explained by Dr. Rodolfo. So we did a trainee-trainer approach where a certain cadre of staff at each of the regional health authorities were trained on how to use the SIP intimate partner violence, sexual violence module. And in that training, an instructional video was also produced and is available online that can assist the healthcare professional to use the actual module. So during that time of the rollout, feedback was received from the healthcare workers on the actual module. So currently, we are revising and incorporating the feedback that was provided by our healthcare workers, as well as internal review. So hopefully in 2025, we would have our SIP, Intimate Partner Violence, Sexual Violence module available to use. And just like for the SIP that was introduced in Trinidad and Tobago in 2018, which started off as a paper-based version, we would first, and then it moved to the SIP Plus, which is the electronic version. Similarly, for this intimate partner violence, sexual violence module, we would like to start off in a paper-based version and then gradually move to the electronic version because we believe that the healthcare worker needs to be familiar with the process and the standardized format and all the indicators and all the data that needs to be collected. And so we believe that they need to be familiarized. And while that process is taking place, we have actually started to develop and to be able to create the safe space for the actual SIP Intimate Partner Violence module. We're actually currently developing guidelines that will guide the regional health authorities to have that safe space for the consultation with the survivor in order to enable this process to take place. So many things are ongoing right now, and it is a time for implementation and to get feedback and so we're currently on the road to doing the implementation. Over
Yes.
to you.
Thank you. Thank you, Roma. And Trinidad and Tobago is perhaps a little bit more advanced in the implementation of this SIP violence module and taking advantage of the toolkit because of all the work that that you've done in helping us to create this regional toolkit and then also piloting it. And I'm curious, then, in terms of the lessons that you can maybe mention to others who will be rolling this out in their countries, if you have any lessons to share, what works well, what doesn't work well, or what type of feedback you receive from the providers, if you can maybe just share some of the lessons.
So I think one of the major lessons came from with the actual implementation of SIP, which is to start on a paper-based version of any type of electronic module or digitalization of health records, to start with stakeholder consultation and training of staff, and to go again and to retrain and resensitize, then do monitoring and evaluation, go in the clinical areas and actually on the ground to see the implementation, to determine what are the issues that persons are having with using the technology, and then to start with the paper-based and to move over to once persons have a handle of the standardized format, to move over to the electronic version. Yes, and also the lesson of creating that safe space to enable this process is very important. You just can't have like the tool without being able to implement and use it. So it's important to have the local context and to go on the ground and determine what is needed for implementation.
Excellent, excellent. Thank you. Thank you, Roma, and thank you for Trinidad and Tobago's commitment to implement this and to generate more and complete data on violence against women. So that concludes our country panel and our country experiences, but we see there's very active chats and comments in the chat and comments section. So I'd like to open up now for questions, comments, further reflections. I don't know if people can have access to the microphone or if we just read the comments in the chats. Britta, do you know if we can give access to the microphone? Probably not, right? No. Okay.
No, but they can add to the chat and we can answer.
That's what we'll do. Yeah, I think we'll just comment. So although the focus of our webinar has been on this new and exciting information toolkit and focus on improving health administrative data, we recognize that because and especially because we're in the 16 days of activism against gender-based violence, that many of you will also have questions and comments just more broadly about violence against women. And I'd like to highlight one of the questions and comments that Razia has posted in the chat regarding what practical role can the Red Cross play in eliminating violence in the context of Afghanistan, but I'd like to maybe expand that question to in the context of Latin America and the Caribbean, which is the geographic representation in which PAHO is working, and recognizing that Red Cross does have presence in Latin America and the Caribbean as well. So Britta, I'm going to move that question over to you if you want to respond.
Sure. So, I mean, I think, first of all, when it comes to this work, including the response to violence, we need every single person and every single organization to act. This is a huge, complex issue, and it can only be tackled through partnership, including with, for example, the Red Cross, but also any other actor that is there. I think from a health sector perspective, we need more people to be trained in what is a quality response. And that includes, for example, training in first-line response, which is a critical intervention that PAHO recommends, including in emergency situations. First-line response, also known as lives or ANIMA in Spanish, is 5 easy steps that any survivor should receive that comes and seek help. That is something that we use a lot in emergency and humanitarian context because it can be a 10-minute conversation. So it can be really quick. It's quite practical and simple to implement, and it can make a huge difference to the survivor because they receive the message that it's good to come forward, that this is not acceptable behavior, and that help is available. I'll end here, and I'm happy to share in the chat resources by PAHO and WHO on this topic. Thanks so much.
Great, thank you, Britta, and also to Rizia, just about the particular needs in Afghanistan. I would encourage you to also reach out to the WHO country office in Afghanistan that also has a role to play in violence and has a violence program. There's another comment I'm going to pull out from Diva in Colombia. Dive dice que en Colombia tenemos información
You're
a
saying
partir
that
del
in
sistema de
Colombia we have
vigilancia
information on the
epidemiología,
basis of
en el cual la violencia
epidemiological surveillance system,
intrafamiliar y de
where
género es uno de los
intra-family
eventos bajo
gender-based
vigilancia.
violence is
Contamos con
one of
un
the events under
tablero
surveillance.
control que
We have
registra
a
en el
control
caso de
panel that
sobrevivientes de
records
violencia
in the case of
sexual si tuvo
survivors of
acceso
sexual
al PET
violence,
kits,
if they
prevención
had
de
access
embarazo y
to PET kits,
prevención de
pregnancy
STIs
prevention, and
VIH, etcétera. O sea que en
prevention of
Colombia ya tiene
STIs and
información y
HIV.
está
So
colectando
Colombia
y
already has
utilizando la
information and is
información a través
collecting
de
and
su
using the
sistema de
information
vigilancia
through its
epidemiológica. Es
epidemiological
excelente. No
surveillance
sé si hay
system.
otros
That is
países que
excellent.
tienen
I don't know
también
whether you
esta
have other
experiencia,
countries
pero
that
también
also
creo
have
que
gone
SIP
through this
se puede
experience, but I
utilizar
believe
de
that
todos
SIP
modos,
can
¿no? Porque
be
es
used
a
in any
nivel de los
case
servicios de
because
salud y
it
no
is at the
a
level of
nivel
health services
populacional
and
donde
not
se
at the
está
level of the entire population
generando la
where
información.
the information is
Y creo que
being
Colombia es un buen ejemplo.
generated.
Sí,
I believe that
exactamente,
Colombia
Silvana.
is a good example.
Colombia es un buen ejemplo como
Colombia is a good
Brasil y otros
example, just like
países que ya
Brazil and other
tienen un sistema de
countries,
información de
because they
salud.
already have a health
Y creo
information
que por
system.
eso tenemos el
And it
kit,
seems to me
¿no?
that
Como
that's
se
why we
basa en
have
las
the kit.
experiencias de
It
esos
is based
países.
on the experiences in
Y los
these
clientes pueden
countries.
revisar los
And
materiales, el
you can
formulario, los
check the
indicadores,
materials, the form, the
las
indicators,
instrucciones, los
the
principios
instructions,
que
the
están parte del
principles
kit para
that are
ver
part of the kit in order
si
to
pueden
see
quizás alinear o
whether you
ajustar
can
su historia
align or
clínica, su
adjust the
sistema de
clinical
recopilación de
history,
datos, su
the data
indicador de
recovery
calidad,
system, the quality
para ver si
indicators,
podemos alinear
to see
todos los
whether we
esfuerzos
can
de diferentes
align
países.
all the
No es
efforts from
necesario
different
usar
countries. It is
el
not
SIP, por
necessary
ejemplo,
to
o
use
otro.
SIP
El formulario
or
puede funcionar en cualquier
other
contexto. Entonces, si ya
modules. The
tienen un
form
sistema
can
de
work in any
vigilancia,
context. If
pueden
you already
también
have a surveillance
considerar si
system,
pueden
you can
agregar
also
a este
consider whether you
sistema
can add
formulario
to this
similar que
system
se basa
a
en los
similar form
indicadores
that is
que la
based
OMS
on
sugiere.
the indicators that you suggested.
Gracias, Britta. Rodolfo, no sé si tienes otro comentario sobre la interoperability de los sistemas.
Rodolfo, do you have any other comments about the interoperability of systems?
Quería hacer un muy breve comentario
Yes,
sobre
very briefly
la factibilidad que tiene el sistema de
about
información perinatal
the
de
SIP
poder embeberse en
capability
el sistema de historia clínica
to
única
include a
que tiene el
baby in
país.
a
Ese es el
single
caso, por ejemplo, de
medical
Perú.
history system of a country. That's the case in Peru. This is the interpreter. The sound is very garbled.
Tiene su propio sistema, que no es el SIP, pero
Other
dentro de
countries
este
have their
sistema
own system, which is not
se está
SIP, but
embebiendo la historia
within this
clínica de
system,
violencia,
we are
una vez que
including
llega la
the
historia clínica
medical
la historia
history of
clínica limpia al
violence.
propio
Once
sistema
this
nacional
medical
de
history is
registro
fed
y
into the system, it feeds the national record system.
La conexión está muy mal.
Perdimos conexión, sí.
The
Lo perdí.
connection, we lost the connection.
Ahí está. Yeah, he's reconnecting.
Rodolfo, ¿tú puedes entrar? Mejoró tu
Rodolfo,
conexión.
Mil disculpas,
no,
se
have you been
desconectó.
able to reconnect?
Pero
Yes, I apologize.
tiene una riqueza enorme.
This is the
Perú
interpreter.
tiene su
The
propio
sound
sistema
is
que ha
very
definido
garbled. Oh, well,
registros
Peru has its own
perinatales, que es el
system defined
WAWANET,
for the
que en ese propio
perinatal
sistema
record, the
se ha
WAWANET,
embebido
a
la historia
system that
clínica de
has
violencia.
included the
Entonces, no hace falta
violence-related
utilizar el
medical
SIP
history.
como
So
sistema
it's not
nacional,
necessary to
pero
use
sí
the
hace
SIP
falta
as a
tener un
national
registro
system, but
electrónico
we do need an
nacional,
electronic
como fue, por
national
ejemplo,
record
WAWANET.
system, such as WAWA, as I just mentioned.
Gracias,
Thank you. Thank you, Rodolfo.
Veo aquí también un excelente
I
comentario
also
de
see
Gloria
an
Carrasco que
excellent
dice que
comment
entiendo y
from
comparto la
Gloria
importancia de
Carrasco
atender la violencia
that
sexual
says,
y
I
sexual en
understand
las
the
niñas y
importance and
mujeres.
share
Sin
that
embargo,
importance
creo que
about
aunque
stopping
estos
sexual
tratamientos
violence
reporten
against
más datos de
girls and
violencia
women.
hacia mujeres,
But
creo que el mismo
I believe that
estereotipo de
the
género
same
puede estar
gender-based
influyendo
stereotype
en
may
un
be
menor reporte de
included
violencia hacia
in a
varones. Creo que
lower
es un tema que debe ponerse bien
volume
sobre
of
la mesa y
violence
hacer uso de
reporting
todo ese
against
maravilloso
males.
instrumento
We need to
para,
be able to
para
use
ayudar
this
también a esta
wonderful
otra
instrument
parte de la
to help
población.
also this other part of the
Gloria, no sé si
population,
tienes algún
males.
comentario.
Excellent point, Gloria. Any comments about this?
No, solamente como
No.
es verdad, como es importante
It's true.
trabajar en los normas de género,
It's
las
important
masculinidades,
to work on gender norms, masculinities, and work and also with women at different parts of society. An advantage of the toolkit and the form is that it can provide data that can be shared by health providers with in the conversation with survivors. So to show that this is not only a good quality system, but also to change the norms with their patients. This is a continuing work which is necessary to be undertaken with all patients, and the health sector has the possibility of making a big difference. Well, I also saw that there's a section for males in the form. Yes, the form, as was mentioned, the form can be used with any survivor. Since data suggests that most survivors of intimate partner violence and gender-based or sexual-based violence are women, we use women, but it's important, it's possible to adapt this form to any type of survivors. We all need to use good quality data. So yes, these tools do work for any survivor, regardless of gender, and the form can be adapted to different segments of the population and different contexts. Yes, undoubtedly. Thank you. Susana, any comments? Brita has just said what I was going to say, that violence is structural in society. We could well be talking about children, elderly person, disabled people, people that are more vulnerable in the violence context. This form has been designed to respond to most common violent situations, which in our society are addressed against women or people that have that gender identity, because now there are many gender identities, but we could talk about transgender, lesbian, transvestite women, all of these individuals that are very vulnerable in society. Violence is structural in society, and that makes it that many people don't recognize it because it is structured. But Brita gave brilliant responses. Thank you. Thank you, Susanna. Now moving to the chat again. I don't see any more questions or comments.
There's just a big one now. De Argeli, que dice, en mi institución se delega a los órganos internos de
Argeli,
control
my
la atención a las
institution
víctimas de
delegates to internal control and organs the care to victims of
ahí está. La atención
harassment.
a las víctimas de hostigamiento y acoso y no tienen
And
conocimiento de atención a
there's no knowledge
supervivientes ni
about
otros
the
tipos de
care to
violencia que
survivors,
se enmarca y
nor of
establece
other
en
types of
programas
violence
institucionalizados.
framed and
Se pasa del
established in
vivir violencia en el
institutionalized
entorno
work. We
laboral
move from
a
living
arriesgar
violent
a
situations
una
in the
denuncia
work
que
environment
se una
to
cadena
risking being exposed
disappearing de una cadena de otras
of
violencias por
other
parte de sus
violences
compañeros.
by
No hay protocolo
managers
personal
and
ni
work
nadie
colleagues, and
competente
there are no
y
protocols,
capacitada que
nor
apoye
staff,
la
no
salud mental y
competent
atención
area
quede como
trained to
mero registro
support mental
administrativo
health
que sucede en el crimen
and
para
to make sure
detectar,
that this is not
prevención,
a
investigación,
mere
resolución de casos
administrative
y
record.
¿qué podemos hacer
What
ante
can
la
we do
negligencia y
given
ignorancia?
the ignorance about that
Fuerte,
this
¿no?
entails?
Pregunta.
A very
Y Brita, creo que
hard
tenemos
question.
todo un
No, y es una pregunta súper
Brita,
larga, ¿no?
this
En el
is a
chat
very
tenemos
long
también las
question in the
respuestas
chat
un
also, but
libro,
the
¿no?
response should
Creo
be
que
would be
es
like a book.
importante como la violencia
it's important. The labor violence is very important. We know that different types of violence have different intersections. This is based on data. So we have to have interventions as soon as early as possible. Before the live, of course, because that is, we emphasize that a child, a boy or a young boy or girl witnesses violence is more liable to commit violence later in their life. So each type of violence needs its own response. What can we do? The good thing is that this is not new. There are interventions based in the best evidence that can have an impact, but we need multi-sectoral policies from different agencies emphasizing violence prevention, protocols at each institution to respond to violence, training of all first-line staff and different institutions, as I mentioned. First lines training, 10-minute training. Each survivor, each violent survivor needs to receive this information. We can use also this in communities. There has been very good work in different countries with the civil society, with when it comes to first line of response. It's not merely a single workshop or policy. It's a comprehensive work encompassing different situations and different actors. There are more comments and questions, but unfortunately we are coming to the end of our session. But I think it would be good to take one more comment because we have 5 more minutes.
From Dr. Paul Bourne that says, with the rise in female participation in major crimes like murder, shooting, robbery, rape, and aggravated assault, and female-on-female participation, how will you, or how can we, address these issues as we seek to address violence against women? So it's like thinking about non-traditional responses to violence against women, I guess. I don't know if there's been discussion about this in the global fora, Britta.
Yeah, I mean, I think you may know that we recently hosted in this region in Colombia the Global Ministerial Conference on Violence Against Children and Adolescents. And I think this is an interesting topic because we increasingly see boys and girls involved in violence in younger ages. And what are the solutions? The solutions are quite similar. The solutions are looking at why do people get involved with violence? Because when they're children, when they're adolescents, we still have a lot of opportunities to intervene and change that trajectory. As I mentioned in my earlier comment, different forms of violence intersect with each other, so they escalate through the life course. And if we have the capacity to intervene and change that trajectory, we can prevent not only that specific act of violence, but we can also intervene in more severe forms of violence later on in life, and we can prevent them from happening, such as murder, major crime, and other things. But that means we need, one, in the health system, the capacity to intervene and identify at-risk groups. We need to be able to provide them with the support they need. That might be support in terms of mental health, it might be support in terms of social services, it might be support in terms of economic services. Access to education for children is, for example, critical for boys and girls to change their trajectory. Safe spaces is an important thing that we need to keep in mind, both safe spaces in school, safe spaces at work, safe spaces in the community. It is about changing norms and this overall the idea that certain forms of violent behaviors are actually forms of communication and they're not seen as violence, and that is something we can change. So there are many different interventions, and I want to just encourage you, because I've very little time, to have a look at the frameworks that are known as Inspire and Respect, that touch a lot of the different evidence-based interventions that we have to intervene with and prevent violence against women, violence against children, violence against adolescents, which are 3 critical groups to look at that also can then involve other or affect other forms of violence later on in the life course. Over. I'll add them to the chat.
Okay, thank you. Thank you very much, Britta. And that brings us to the closing of our webinar. And I'd like to thank all of the presenters, our country panelists, you, Britta, and Aaron, Rodolfo, Susana, for your collaboration and showing us the demo of the SIP. And I hope you're as excited as I am about our new toolkit from PAHO. So thank you to all the participants. We had close to 180 people showing the commitment that exists in our region to improve data and improve the health system response to violence against women. And this webinar really marks a significant milestone for us at PAHO in the collective effort that we have with all of you in the ministries of health in Latin America and the Caribbean to strengthen that health system response to violence, including the strengthening of the health administrative data on intimate partner violence and sexual violence. And this work is all aligned and in support of the PAHO strategy and plan of action to strengthen the health system response to violence against women. So I just want to reiterate that from PAHO across the programs of violence, women and reproductive health, and other programs at PAHO, we really are committed and stand ready to work with all of you in the ministries of health and together with our civil society partners and other UN agencies to strengthen the health administrative data, but more importantly, to strengthen the health system response to violence against women. And please check out the links that we've put in the chat where you could download this new information toolkit. And you can also check out the links on the PAHO website for violence, where we have our toolkits on respect and inspire that allow you to have more resources to strengthen the health system response. And I just want to conclude by again thanking the Spanish Agency for International Development Cooperation, IESID, and it's really thanks to their support that has allowed us to develop this information kit and to do all this amazing work on violence against women. So, it's been said over and over again, but I can't say it enough that together we can really work stronger and better to end violence against women and girls. So thank you to everyone for your commitment to this important public health issue and for your participation in the event and using our toolkit as we launch it today. So thank you, everyone, and have a great day. Muchas gracias a todos y a todas. Que tengan un buen día. Chao, chao.
Felicitaciones a todos.
Thank you, everybody.